Hello and welcome to Chapter 9. Here we will discuss chronic illnesses and disabilities. When we look at chronic conditions, you want to understand what a chronic disease is and how it's referred to as different things, such as your non-communicable diseases, chronic conditions, or chronic disorders. In contrast, chronic illnesses refers to the experience of living with a chronic condition or disease. You also want to note that chronic diseases are the most common causes of death within the U.S. So know the difference between both an acute and a chronic disorder. Of course, your chronic disorders or conditions are those lasting longer than 3 months. When we look at other countries besides the U.S., you want to note the morbidity and mortality rates are actually decreasing due to increased or improved nutrition. So that is an interesting statistic that they often speak about because we're always interested, or shall I say worried, about the increasing rates of morbidity and mortality. But apparently other countries have it right and they're improving their nutrition as well as utilizing complementary and alternative therapies, which in turn decreases their mortality rates. But you still want to understand that they still have chronic conditions and they are still dying from those conditions. When we look at the causes of the increase in chronic conditions, of course we want to look at lifestyle factors, the longer lifespans, improved screening and diagnostic procedures. So people are living much longer with these chronic diseases versus decades ago when they would be diagnosed and they wouldn't live very long afterwards. Going over the characteristics of chronic conditions, we'll look further at these. First, we'll look at managing chronic illnesses. Actually, note that this involves more than just treating the actual medical problem. Associated psychological and social problems must also be addressed because living for long periods of time with illness, symptoms, and disability can threaten identity, bring about role changes, alter body images, and also disrupt lifestyles. Chronic conditions usually involve many different phases over the course of one person's lifetime. These can include acute periods, stable and unstable periods, your flare-ups, and even remissions. Each phase brings its own set of physical, psychological, and social problems, and they each require their own regimen and type of treatment and management. Note that keeping chronic conditions under control requires persistent adherence to therapeutic regimens. But with that being said, you want to also understand that people living with these chronic conditions have to be able to care for themselves, and if they're not able to care for themselves, help their caregivers or family members understand that they have to care for the patient or allow the patient to care for themselves in their own way. Help them to individualize a plan that works for them. Note that one chronic disease can lead to the development of other chronic diseases or conditions, such as diabetes. This is an example. If a person has diabetes, note that it can lead to neurological or vascular changes that may then result in visual, neurologic, cardiac, and kidney disease, and even erectile dysfunction. Also note that the chronic illness affects the entire family. Family life can be dramatically altered as a result of role reversals, unfilled roles, loss of income, time required to manage the illness, decreases in family socialization activities, and the actual cost of treatment. So when a person is diagnosed with a chronic condition, it just does not affect that person, but it affects everyone within that family unit. More characteristics of these chronic conditions, we look at the day-to-day management of this illness. It is largely the responsibility of the people with the chronic disorders and their families. As a result, the home rather than the hospital is the center of care in the chronic condition. The management of chronic conditions is a process of discovery. People can be taught how to manage conditions. However, like I said before, each person must discover his or her own body and how it reacts to the varying circumstances. Managing chronic conditions must be a collaborative process that involves many different healthcare professionals working together with the patient and their families to provide a full range of services that are often needed for management at home. And lastly, the management of those chronic conditions can get expensive. Although insurance may cover a lot, some insurances don't cover very much. So this can get very expensive because depending on the age that the person is diagnosed and how much medications are going to cost and the type of treatment that they will need, this can get very expensive for the patient and their family members, especially if the patient that is diagnosed with the condition was the person bringing in the income for the household. When we look at managing those chronic conditions, the importance of it is prevention, but we cannot prevent every single thing. So, if the patient is diagnosed with a chronic condition, of course, we want to try to alleviate or at least manage those symptoms. Care regimens as prescribed. You want to normalize their personal and family life as much as possible. Although this chronic condition will throw them for a loop, we want to kind of get them back into the stream of things and how they were doing things, especially if the chronic condition isn't very debilitating. And then you want them to be able to return to a satisfactory way of life after an acute debilitating episode, such as those that they are going to have remissions or flare-ups or things of that nature, such as lupus. That's a chronic condition as well. And then lastly, if they need to die or they're in the dying process, I'm sure no one needs to die. If they're in the dying process, you want to help them and their family members do it with both dignity and comfort. Of course, the main goal is health promotion and health maintenance and getting them back to that independent, steady state. And here's a question in regards to what is considered a medical chronic condition. And the answer with the rationale. And then let's look at some of these challenges of living with a chronic illness. Note that, of course, we want to alleviate and manage those symptoms like I talked about before. We want to validate the individual and their self-worth and the family functioning, of course. We want to prevent or manage crises if it does occur, any complications. And as stated before, we want to normalize that person's life. We want to get them back to their normal, steady state if possible. Establish networks of support resources will be their best friend. And, of course, in the end, if they're at that dying process, we want to help them do it with both dignity and comfort. Now we will look at the nursing process. You will never be able to get away from the nursing process. It will follow you for the rest of your healthcare professional life. So when we look at treating or utilizing that nursing process for a patient and their families with chronic illnesses, we want to go through the 5 steps. Of course, identifying specific problems and the trajectories. And I do want you guys to also look at table 9-2 in your text on page 137 that goes over the phases in the trajectory model of chronic illness. So when we look at step 1, of course, we'll identify by assessing the patient to determine the specific problem identified, and you will work with the patient and their family members as well as other healthcare providers. Once we have established what is actually going on and the trajectory phase of their disease or disorder, we want to establish and prioritize some goals. Of course, make sure your goals are measurable and obtainable. If the patient, let's say, has Parkinson's, you don't want to give them a goal where they're not going to be shaking at all anymore. Of course, we will give them some medication, but they may still have tremors at some point. It's not going to go away completely forever. So, make sure your goals are realistic. Prioritize them in the order in which they should occur. And make sure you include the patient and their families, because like I said before, most of this care is going to take place in the home. So you first want to make sure you give them goals that are obtainable, but make sure you include the family members as well, because they will be there with the patient as well. After you have done those goals, you want to define the plan of action to achieve those desired outcomes. So goals are established. Of course, it is necessary to identify a realistic and mutually agreed upon plan for achieving them, including specific criteria that will be used to assess the patient's progress. Step 4 is implementing that plan and those interventions, of course, making any changes if necessary. And then 5, you'll want to follow up and evaluate those outcomes. See how those goals work. See if, they were able to meet those goals at the end. You want to help the patient and the family members integrate changes into their lifestyle. It is an important part of the process. Of course, we want them to be able to go about their normal daily routines, so they may have to tweak the plan a little bit to accommodate their daily lives, but as long as they're doing what works for them as well as following the plan, then we're all one big happy family. If it is not going according to plan and they're not sticking to the regimen, then of course we want to come back in and redefine those goals and see what is actually going on. You also want to make sure that the patient and the family members understand what it is to have a chronic illness. Not only does it last more than 3 months, you want them to know that cures are rare, that the disease or disorder will not resolve spontaneously, and that they will typically have a prolonged course, if not a lifelong course. So you want them to be aware of these types of things, because some people may believe that once they start treatment or have this plan of care, that the disease or disorder will actually go away, when that is certainly not true. Now we'll talk a little bit about disability. You want to, of course, know what disability is and how it's defined. Know that a person is considered to have a disability, such as a limitation in performance or function in everyday activities. If he or she has difficulty talking, hearing, seeing, walking, climbing stairs, lifting or carrying objects, performing ADLs, doing schoolwork, or working at a job. A severe disability is present if the person is unable to perform one or more activities, uses an assistive device for mobility, or needs help from another person to accomplish basic activities. People are also considered severely disabled if they receive federal because of an inability to actually work. And here are some statistics on the prevalence of disability. And I also want you to look at chart 9-3 in your text on page 141, which goes over a summary of facts about the population of people with disabilities. Now we'll look at the types of disabilities. First, we'll talk about developmental. These are the ones that you may see more often, and your developmental disabilities are those that occur anytime from birth to 22 years of age and result in an impairment of physical or mental health, cognition, speech, language, or self-care. Examples of those, of course, are your spina bifida, cerebral palsy, Down syndrome, and muscular dystrophy. When we look at acquired disabilities, these may occur as a result of an acute or sudden injury, such as traumatic brain injury or spinal cord injury. You want to know that most of the people with disabilities are able to live at home and independently. When we look at those age-related disabilities, you may see those that have dementia or Parkinson's or Alzheimer's, things like that. They're related more to an age of onset type deal. And those people usually need their families or caregivers to help them with coping and independence of living. If the family members or caregivers cannot do so, these people may need special or alternative living arrangements, such as your assisted living facilities, long-term care facilities, or even the group homes. And I did want to give you one example. Going back to our developmental disability, if you are caring for a patient that does have a developmental disability such as Down syndrome or even spina bifida, and they come into your care, but you're taking care of them for, let's say, community-acquired pneumonia or CAP, you still want to note that they have that developmental disability. It is not necessarily the pneumonia that is disabling them. It is the actual developmental disability that they have prior to you treating them for the actual acute disorder that they have. Because the pneumonia should indeed go away, but their Down syndrome or spina bifida will not. So know the difference in those, especially when you're documenting and taking care of those types of patients. Briefly look at the models of disability. Those are listed in your chart 9-4 in your text on page 142. I also want you to look at chart 9-5 in your text on page 143, and that goes over the strategies to ensure quality health care for people with disabilities. We should not ever discriminate against people with disabilities, and we should not look at just the disability when caring for these patients. We have to care for the patient and see the patient as a person, not as their disability. The disability does not make the actual person. Here's a true or false statement regarding disability. And the answer is false, and here's the rationale. And now we look at questions to ask to ensure quality of care. And that again is in that chart in your text on page 143. I also do want you to look at interacting and communicating with people who have disabilities. And we talked about that briefly in class. and how to handle some of those situations, such as your hearing loss, your vision loss. Go ahead and look at mobility limitations and speech disabilities or speech difficulties, and that is listed in your chart 9-6 in your text on page 145. Looking at accessibility of healthcare, people with disabilities have the right to access healthcare that is equal in quality to that of any other person. Note that we cannot refuse to care for a person that is disabled. So note that people with disabilities have the right to health care provided by professionals who are knowledgeable about and sensitive to the effects of disability on access to health care, including care that addresses their reproductive issues and sexuality. And I did want to touch on that a little bit. When you are assessing and educating patients who have disabilities, one topic that most healthcare professionals overlook completely is sexual health. I'm not sure why. I'm not sure if they believe that disabled people cannot have a healthy sexual relationship, but that is untrue, and that is a myth and a stereotype. So make sure that you do include that when you're assessing and educating these patients, because that is one of the major areas that is overlooked for this population of people. So when we look at health promotion, of course, we do not neglect health promotion issues. We want to educate them on the need for a healthy diet, exercise if they're able to do so, social interaction, and preventative health screening. So note that the general health promotion strategies and health screening recommendations that are listed for all men and women also apply to those with disabilities. Just because the person has a disability does not exclude them from the population. We just have to pay close attention to that disability. If it does not affect their overall health, it may have been something that debilitated them earlier in life that they had no control over. So we have to give them the benefit of the doubt. As nurses, we can provide excellent health promotion education classes that are targeted to people with disabilities and refer them to accessible online resources as well. The need for health promotion in areas of establishing relationships, sex, pregnancy, and childbearing is as great in people with disabilities, including those with intellectual and cognitive disabilities, as any other person without. Now we'll look a little bit at the importance of language. I spoke a little bit about this before, using the people first language. And I didn't define it, I just kind of briefly talked about it. But the people first language means that you want to refer to the person first. And there's a good example in your book. That means referring to the person, not the patient with diabetes. You want to refer to them as Mr. or Mrs. Jones or whoever they are. Yes, they have diabetes, but don't just, say it's their disorder. Say, the diabetic or the Parkinson patient or the schizophrenic patient. The one with the red hair, the red-headed schizophrenic. Yeah, that's not okay. So you want to see your patients as actual people first. So, yes, Miss Jones may have red hair and she may be schizophrenic, but we want to address Mrs. Jones if she's not charging at us, trying to kill us, okay? So, you do want to address the person first. And also, while we're talking about addressing the person that has an illness may need a service animal, and this has come up not too often, but we have had some miscommunication about it. If the person or patient uses a service animal and they are admitted to your healthcare facility, note that arrangements can be made to have their service animal with them in the actual healthcare facility. And lastly, we'll look at the gerontology considerations. Of course, this is the group of people that we're going to focus on in each and every chapter because everybody's getting older. No one's going to stay young forever. So we have to talk about this population. And this is the population that you will see more often unless you're in those specialized areas that do, pediatrics or neonates or women or, your surgical oncology or things like that. You're going to run into the elderly population. So the rates of disability also increase with age, but we don't want to be discriminatory when we say, all old people have a disability. That is so not true, and that is a stereotype. So we don't want to do that. But we want to understand the effects of aging and how this affects their disabilities. A person that has a disability that is 67 versus one that is 97 may differ versus the person that's 33 and has the same disability. So we have to look at age as well as the age of the caretakers with people that have disabilities. So age affects this as well, whether it be for the patient or for their caregivers. Concern about what the future holds is common in people aging with persistent disabilities who may have questions about what physical, financial, and emotional supports they will have as they actually age. As the nurse, you should recognize the concerns of people with disabilities about their future and encourage them to make suitable plans which may relieve some of their fears and concerns about what will happen to them as they actually get older. And that will conclude Chapter 9, which goes over chronic illnesses and disabilities.